Good morning, good afternoon, good evening, everyone, wherever you are. Thank you very much for joining in the discussion today with Baba Aye, Health and Social Services Officer of Public Services International, PSI. We're extremely happy to have you back, Baba. Thanks a lot for making time. We know many things are going on, and in particular, you are back home and your own organization. So really, really thank you for finding time for this. And today we have really the topic, a very important topic on the vision of the Public Services International, the Global Union Federation of Public Sector Workers on public services. So very glad to have you, Baba. And if you can, people have watched your video lecture for sure. So if you can tell us something about these key elements of the vision that you think are worth highlighting just to kickstart the conversation. So thank you again.
All right, thank you. So yeah, our vision on public services and also looking more particularly at health and social care. One, we are strongly of the view that universal access to quality public services is essential for building democratic societies. It's critical for expanding social justice. And so it's not just about the services themselves, which of course are part of the economic, social, and cultural rights of people, democratic rights of people. It's also about building more inclusive societies. So that undermines our politics as PSI. It informs our organizing. And we do realize, as I said last week, you need a strong workforce in the public sector to deliver quality public services. But you also need workers' power. You need to build workers' power to bring to bear the collective associative strength, powers of these workers in shaping the kind of quality, the kind of public services we want, which are quality public services. Now, relating this to the issue of health, PS has consistently stood up for the full realization of the right to health. And with all that's access to universal public health care. We are sort of we caution when you see UHC as universal health coverage, which is what you have the World Health Organization defining it as, what you have as the Sustainable Development Goals target, because that coverage insurance language bit is not accidental. It's part of the corporatization and commodification of healthcare that has to be pushed back in praxis and in ideation, in the narrative, as well as with policies and programs. So for us, we talk more of universal health care, which is achievable only as universal public health care. So for us, that amongst other things means that every human being, irrespective of her or his or their status in life, should be able to get quality public health care, publicly delivered, publicly funded, free at point of need. And you can see the difference which the NHS made in the UK, for example. So you can say we want the NHS Plus, unlike now that you have even the attempts to roll back some of the gains of the NHS with some elements of public-private partnership and other forms of privatization. So circling back to frontally addressing the question, our vision is of a better society with universal access to quality public service at the heart of this, of which having the right to health as a palpable, concrete reality is pivotal. And we need to build workers' power to bring this to bear and to, entrench the expansion of such rights being realized by everybody on this our great planet that has been despoiled by the same forces that are commodifying our health and indeed trying to corporatize public services delivery with new public management. Thank you.
Thanks a lot, Baba. We have had also questions that came when people registered for the workshop. So I may pick up on those, but let's first open to people. And Ian, you made a question in the chat, when registering for the workshop that was very interesting. So I'm calling you if you want to make that question directly to Baba here. Thank you. You're muted, comrade.
Could you remind me about the questions? Because I have lots of questions.
Oh, but I mean, your question that was here was how can the Global South prevent the brain drain to the Global North regarding health and social care services, which of course is a critical question because that's what Baba has been emphasizing again and again, the critical importance of health workers and of workers in general for public services. And that's a critical question, but you can do whatever question you like to Baba, of course.
Well, just to expand on that, I'm from a small island development state in the Caribbean, Antigua and Barbuda. Over the years, we have had like booms and busts in terms of the amount of healthcare workers. Despite all the programs the government may have in place in terms of scholarships, upgrading educational institutions, over the years, we've still seen the brain drain take place, probably because, well, at least from my viewpoint, some of it has.
I lost him. Did everybody? Okay, I thought it was just me. Ian, we kind of
lost.
Yeah,
I lost him too. Okay.
Baba, while we're waiting for Ian to connect, perhaps he even dropped out. And really, his question is about the brain drain and what can the countries in the South do? And perhaps when he's back, he can pick up on that. So, but could you perhaps start responding to that?
Oh yeah. One, I think it is a shame that the countries that have the greatest disease burdens are the countries that have not only the least number of health and care workers, but they even have these health and care workers, sucked out of them. And for example, when you look at the 55 countries on the critical list of the World Health Organization, and countries where there is need for safeguards on healthcare workers, I mean, they are all in the global South, not surprisingly, and about 45 of these are from countries in Africa. Although that's because the WHO regions, you have the Eastern Mediterranean region, which incorporates some parts of North Africa. So by their regions, some of these are not in the WHO Afro, but when you look at the continent, they're still part of it, also like Djibouti. And so, but these are the countries where you have health workers being sucked, not even only to the global north now, but even also to some other countries in the global south. Like, for example, you have in health workers from Ghana, the government itself entering into agreements with the Barbados government. Then you're having in Nigeria, I was even shocked when someone was saying that, look, about 100+ nurses had been scammed by a recruitment agency promising them jobs in Jamaica. So now, what is to be done? How do we address this? And which is Ian's question. First is the need for improved living conditions, improved and the decent work, because it's not even just only about the work in these countries, in the health sector. It's also about even the social and economic determinants of health in this country. They don't have enough doctors, but even there are still so many that are unemployed. And why is this? Is that in a lot of these countries, IMF conditionalities from borrowing forced them to have ceilings on employment in the public services, and which affects the health sector most, as well as caps on wages. So we need to fight for such conditionalities to be removed. These are things that constrain the possibility of attaining the Sustainable Development Goals. So you're having verbal commitment to attaining the Sustainable Development Goal, but putting in place those policies, international financial institutions that constrain the fiscal policy space of countries in the global south. So this is important, but it's also because whilst we want to, I don't like using these push and pull factors as they usually say, but I can't immediately think of any other thing. While we need to look at push and pull factors, we must also not shy away from the fact that migration is also equally a fundamental right, but it is that it upends, in these cases, already weakened health systems. So, but then how do we make migration fair? How do we ensure recruitment when this takes place is ethical? The way to go about this is to ensure tripartite structures are involved in coming up with bilateral labor agreements between countries of origin and countries of destination. PSI has done this successfully in a number of cases, especially we started this with Germany and the Philippines. And this has served as a model that the WHO, the ILO have referred to several times. Then for us as unions, we also came up with what we call the worker passports. And this is where you have, when workers were going, unfortunately, it hadn't been sustained. It was part of a project, but I think it's one of those things that we need to get back to, because this was even before I joined the PSI. This was when I was I was co-chair of the Nigerian National Working Group on Migration. Where those workers that, nurses and other health workers, they were enabled to be able to join the sister union, also PSI affiliates in countries they went. Then it was mainly, UK and with Unison, then even also Australia. And over there, as soon as they got there, also they were able to have access to the unions and, explicitly taking them through their rights. Because people often forget, when people get to a different country, different culture and things like, there are a lot of things that you don't immediately get. So having a union by your side that takes you through this is also of utmost importance, is very, very valuable in overcoming the immediate challenges that health and care workers face. So it's a two-way thing. We need to try stem the tide of migration, but we also need to ensure that the migration that takes place is on fair and ethical basis.
Thank you, Baba. I think the point you're making about the determinants of health, the social and economic determinants of health, it's really important, but it's important also for the global north, because there is at the same time many health workers in the global north are leaving the profession exactly because of the very difficult and intensification of jobs in the north. And then these people that are coming are actually taking jobs of a lower quality. So the question of health determinants, and then all the questions are equally relevant and important, both in the global north and in the global south. So I think that perhaps having this health determinants as an overall framework becomes really an important focus when it comes to responding this kind of questions. But thanks a lot for that. Somebody else would want to make a question to Baba? I mean, have the possibility. Celine, I saw your question, but I think that's a bit more technical and perhaps not in the field that we are currently looking at. So perhaps somebody has a bit of a question more on the political economy and the topic that we are discussing. Because if not, I can still pick up another question that was made by Fish Ip Baba about the fact that in Asia, many countries have community healthcare workers who are government volunteer under these government volunteer schemes, which, you know, of course. So what would be your views on that?
That's a very good question. First and foremost, let me point out that a lot of these so-called volunteer community health workers are actually not volunteers. They have been exploited as cheap health workers. And we as PSI, we've committed significantly politically and materially to challenging this, in building workers' power of community health workers in South Asia and Southeast Asia, but also increasingly now in Africa. We've also, apart from building associative power, we've also been involved in building institutional power, so to speak. I was, for example, on the World Health Organization guideline development group that came up with the WHO guideline for the optimization of community health worker programs. And one of the explicitly spelled out guidelines there was that when people work normal working hours, 35 hours, 40 hours, you can't call them volunteers, for goodness sake, simply because you choose to not want to pay them wages, so that they should be paid wages. Now, institutional power is useful, but you can't force governments to take policies without that associative power, without workers' power. So I'll talk quickly about what we did, particularly in Pakistan, and look at a few other countries there. In Pakistan, PSI supported the all lady health workers, ASWAs, Lady Health Workers, all Sindh Lady Health Workers Association. And they used several tactics. There were demonstrations, they went to the courts, they, got legislation. And what were the demands? The first was to be clear that they were workers, and two, for remuneration that was up. So we first won in the court of that, look, they should be paid not less than the national minimum wage. That's to say, they shouldn't be considered as volunteers, but they should be paid wages. Then they won the right to collective bargaining, which then also served as that's recognition as a union and with a bargaining certificate. Similarly, in India, in the state of Mumbai, we won the recognition of community health workers, even though they were labor brokers in between, but won the recognition of the fact that the Mumbai, Mumbai is the city, not the. I think the state is Marrakesh, but we got the Mumbai City Council was recognized as their employer. And had to bargain with them, also resulting in improvement. And this was the ASHAs going on in this direction as well. We hope to have similar victories in the coming period. Then in Southern Africa, starting with South Africa, members of our affiliates were able to support community health workers in Gauteng some years back to win recognition as employees and then be paid. And just on May Day, our affiliate NUPSO, organized its members that were community health workers, organized mass demonstrations to demand for recognition of the workers' rights of community health workers, including of so to sum up in response, first and foremost, the characterization of all community health workers as volunteers is false. It's a false narrative which feeds making them get shitty, pardon my French, wages and working conditions as cheap labor. And we need to stand up against that. We need to stand by the community health workers as playing critical roles in health systems in several countries.
Thanks a lot, Baba. There is a comment in the chat from Ian, but before that, Agnes has also made a comment when registering for the course. Agnes, would you like to pick up on your comment? Okay, well, we get Agnes. Ian, do you want to read your question?
Yes. I was just basically asking, what are the best strategies for getting undocumented or informal care workers formalized and unionized?
Yeah. So that's a good question. First, the concept of the care economy and what constitutes care work. It's a very broad thing at the moment, and it covers and different segments, different sections of care workers or workers in the care economy utilize different strategies. There are some universally cross-cutting strategies and also tend to have different extent of undocumented workers at their crux. For example, when you talk of the care economy now, you also talk of domestic workers, but when you're talking in the strict sense of, social care, they wouldn't be covered by that. But you tend to have a higher rate of irregular or undocumented migrant workforce in that. So how do we organize this? What are some of the strategies that have worked? Let me start with that way. We have had strategies that included like this. We have, I'll give a concrete example. We had an Indonesian document on domestic workers in places like the Netherlands organizing. The essence of that is you have a commonality of language, things like that. Some of those even just arriving might not have learned the Dutch in this case. So it was easier to draw strength from quote and unquote the informality in this sense, the national shared language. But beyond that, in the bigger picture for us as PSI, getting informal workers organized, it's important the union is involved. It's important the union is involved, but a number of our unions are used more to the formal sector. So you have had what you call associative bodies to the formal sector unions. and which supports the informal undocumented workers, not only with room, creating space for bargaining, but even things like lawyers to support their processes of getting documented. So it's trickier. It's trickier, but it is important because with the care sector expanding, you're having increasing both documented and undocumented workforce expansion. But different strategies work at different times in different places.
Thank you, Baba. Baba, perhaps I do read the question of Agnes as she's not responding. So she asked, and I think it's a question we get often, right? Like as if there is something specific about the continent. But the question is, can healthcare be fully public in Africa? So if you can speak to that.
Oh, I'll say the answer is yes. The question is, why hasn't it been? Because this was the aim, the goal in the 60s when which was the decade of independence in Africa, really. And you will see that you had in Africa then the things went, there were leaps and bounds in terms of building of hospitals, health centers, increase of life expectancy, and so on and so forth. And it was because government committed significant amount of money to healthcare because they realized health is not, some will say health is actually even more than wealth. You know, it's not just that healthy people are more productive people. We shouldn't just take a productivist or wealth dimension to, there are intrinsic elements to being healthy. It's about, it's central to our being human. But what happened? What happened started with SAP, the Structural Adjustment Program, the Beggs Report of 1981, the introduction of user fees, and the advice of governments to cut down on funding for health. In the late 80s, most African countries, over 80% of African countries, cut their budget on health by up to 50%. In some cases, like Nigeria, by up to 70-75%. They never came up to this, came up to the kind of the level of funding that was put into health care in the 60s and early 70s. In 2001, April 26, 27, African leaders met in Abuja, where I am right now, and they passed the Abuja Declaration. And even by their own acceptance, there was gross underfunding of healthcare. And they committed to all the countries increasing the proportion of their annual budgets that will be committed to healthcare to 15%. This is 23 years later. In these 23 years, just about 6 countries have at any point in time whatsoever done that. As of 2 years back, only Cape Verde and either South Africa, just 6 out of 56 countries. And that is why for us as PSI, in conjunction with the African Health Sector Unions Council, we kicked off a 2-year campaign on the 23rd anniversary of the Abuja Declaration to put pressure on the governments of countries on the continent that, 25 years is enough time to live up to a promise. By 2026, we expect to have, this commitment of 15%. So the funding, and it's not just about the government, it's also about, and that's why I spoke earlier about international financial institutions, curbing fiscal policy space and all that. These are all the things and that's why I started with SAP. So we can, and we have to ensure universal health care.
Thank you very much, Baba. Any other question or comments to what Baba was presenting in the arguments? Yes, Benji.
Hi everyone. Hi, Comrade Baba. We watched a movie called Spirit of 45 about the transformation of basically the economy of Britain, where a large segment was transformed from private businesses to public services, right? Including the health sector, right? In the Philippines, however, we have this fragmented health sector where there's private and public, and of course the private health sector provides better services, and the public health sector is underfunded, right? And within the public health sector, you also have this like segmented workforce. You have a more formal sector where you have doctors and nurses who are formally employed by the government and have security of tenure, etc. But you have informal workers. We call them barangay health workers. I guess they're the equivalent of what was asked earlier as community health workers on a voluntary basis. Of course, there are calls here also to formalize them. So I guess my question is, do you see the same things in in the countries where PSI has affiliates? You have this like fragmented health sector into public and private, and also the workforce divided into formal and informal. So what is the position or demands of PSI with regards to this?
Thank you very much. And I think it is very, very significant that you started with the spirit of 45. It did not just happen. What happened in 45 was because there were struggles by unions for much more than just a reform of the system. They struggled for post-capitalist alternatives to the failure of capitalist relations, which, amongst other things, threw up the Great Depression, threw up the World Wars, and this you had the sit-ins in the US, you had hunger marches in the UK and all that. People demanded more. So it was not out of the benevolence of the British states or the British bosses. Now, they managed over, well, some described it as a counter-revolution, the neoliberal counter-revolution, starting with Chile, 73, Reagan and Thatcher. And you now have the common sense of this mythical power of the private, this mythical utility value of the private. And when you look at it, this then shaped even things like not only the health sector in terms of cuts in the funding, in terms of public-private to even privatization, even things like the NHS that you have now. You have privatization in the form of public-private partnership. But it also shaped the policy on the health workforce. The idea of the community health workers dates way back from the Chinese doctors without shoes, but when it was then adopted, the Alma Ata Declaration of 1978 was where, in fact, the conference was on primary health care, and community health workers were to be at the heart of the primary health care. They were not supposed to be the way it is seen now as just cheap workforce. Yes, they were supposed to be volunteers that were people living in that society, in those communities, you understand, that could bring to bear their authority to get, because it's also not just enough for health for it to be delivered. The people need to be involved in the formulation and implementation of policies shaping their health. But workers are not volunteers. Those that are to do this on a full-time basis are supposed to be integrated into the health system. There was a gap between 78 and when most of the community health workers program kicked off in the 80s, 90s, and then with vehemence in the 2000s. And what happened between that 78 and 80, 90, what happened was that was a period in which the spirit of 45 was being strangled. That was the period people like Margaret Thatcher were beginning to tell us that there's no alternative to the neoliberal paradigm. And that was the period when the whole idea of what the community health worker was to be was also reshaped. It was now more of the cheap labor bit. The vision of Alma Ata was distorted. And this takes us back to the issue of the broader social and economic context. When people talk of the Alma Ata Declaration, I believe most of us were familiar with it, but if not, please, it's a must. I think it's one of the most significant documents on international health. People often forget that it was stressed there that was when the Health for All slogan came up, because the Alma Ata Declaration set the goal of Health for All by the year 2000. And one of the things there was that it was explicitly put that to get Health for All, there was the need for a new international economic order. You know, and that is where we are now. It is impossible to change things on the basis of the neoliberal paradigm, which is what shapes such fragmentation. We can win some concessions, we can do some pushback, but to fundamentally and holistically change things, we need to change the system. So that is why we're fighting on two fronts. We're fighting for the granular issues, but we're also fighting on the systemic issues to change the nature of the system within which these granular issues that you pointed out exist. Thank you.
Yeah, thank you, Baba. And that really connects very well to, under your video lecture, you know, there are people commenting about what you said and some questions we are asking them. And one of them is actually making a point that how helpful is a discussion on rights? And I think the discussion on rights, perhaps in the context of the current economic and political order. So on the one hand, you have all these international treaties and the countries are signing up to those treaties, but at the end, you go home and then what you mentioned, that the budgets keep being cut, and there are some examples even under your video lecture where the participants are saying that we are still under pressure to actually cut the health budgets. So perhaps if you can expand on that. I mean, one could even argue that the discussion on rights has only served to kind of make us feel a bit good about declarations of the right to health and so on. But at the very end, everybody that is signing up to those know that there is not much that they can actually do. So how do you actually handle that? How do you still keep passionate about the discussion on the rights, knowing all these constraints? Perhaps that would be the best question I would want to ask.
I can't remember who said something to the effect that we keep fighting till we win. And we should also not forget, yes, and I think this is part of what many find frustrating, how those that have absolutely no intention of granting the full realization of the rights they mount it with such sophistication. And that speaks to the hypocrisy of those that rule the world. And you find such hypocrisy showing itself in several ways, of which rights is just one. Another has to do with wars. I mean, you can see the position that was taken on the international courts of justice and Putin and in the Ukraine war. And now they are taking things now with the Gaza war, but it did not even start with that. I remember the Director General of the WHO, Dr. Tedros Ghebreyesus, having to point out when the Ukraine war started that, oh, it was very good that such attention was being paid to the Ukraine war, the war in Ukraine, but it was quite curious that you didn't have the same kind of passion about the war in Ethiopia that had claimed much more lives than even after 2 years or so you've had of increase. So there's this hypocrisy, but we should not allow the hypocrisy of those that mouth the same words to make us think that we need to stop talking about them. It's that we need to start fighting more for them. And part of why it's also, I mentioned one of the frustrating, part of the second frustrating me, for me as someone, I would say, look, I'm a soldier, I'm primarily a fighter, and being in the international trade union movement is a bit frustrating. Is that politics, campaign, the most concrete of struggles are on the ground. They get the more local, the further away from the ground you get, the more stratospheric it appears. You know, so the thing is also how to tie the ideational war at the international with the regional with the national and the local. And that is why Global Union Federation's places are very important. But even much more important for the Global Union Federations to have their affiliates at the heart and soul of what they do, which is for us as PSI central to our work. You know, we don't just do things for the affiliates as PSI. The affiliates, and for me, I joined PSI 8 years back, but I'd been part of an affiliate for almost 2 decades before then. And one of the things, even as an affiliate, that was ingrained in us was that, look, the head office is not PSI. The affiliates are primarily PSI. So, but the head office is meant to and has to and does support and sustain struggles on the ground as much as we can, whilst taking up the debates globally and internationally, on rights, supporting this with research and evidence, but the main fight has to be on the ground. Not that the fight internationally is unimportant, and not that the mounting of rights by those that are just mounting it cannot be kind of disappointing for the person that raised that question. But we have to keep that flag flying. We have to keep that flag flying and make the linkages.
Thank you. Thank you very much. Any other question or comments? We have about 10 minutes before wrapping up. if somebody would like to ask something. If not, Baba, at the end of your video lecture, you talk about changes that have to happen at the WTO. In particular, you take on from the vaccine discussion, but I think you are making even a broader point about, and I don't know whether you would call it that way, but really the immorality of letting such important decisions about the health of people in the world, but even about the planet, and leaving that to organizations that are giving priority to corporations and the right to profit over people's health. So perhaps also to wrap up this session, and I think you hinted to that, the importance of fundamental changes in the global political economy system. What would you say to that point? Thank you.
Thank you very much. Yeah, the COVID-19 pandemic revealed quite a number of things. For one, it confirmed our fears. Talking about the last thing we talk about now, the hypocrisy of those that rule the world, because the fact that the WTO did everything possible to avoid, the utilization of the TRIPS waiver, despite the fact that lives were being lost, is.
Baba, you muted. Sorry.
Okay. Yeah. Sorry. Yeah. So it's quite shocking that despite the fact that that might have saved lives, and who were the people that benefited from this? A handful of corporations and people, 32 new billionaires that were tied to vaccines and other pandemic products. So for us, there's the need to include the automatic waiver of patent rights on pandemic products, and even generally on issues on things concerning health. But even that on pandemic products, which we have put forward to the intergovernmental negotiating body of the WHO on the pandemic accord, has not been welcome. The powerful countries have done everything possible to frustrate this. So talking of the kind of world we need, I spoke of Alma Ata before on the need for a new international economic order. They were drawing from a language of that period. As would remember, in 1974, the United Nations actually passed a resolution for a new international economic order based on the advocacy of countries, mainly from Latin America, but also, the non-aligned countries, the movement, also Africa, Asia, and all that. It was never implemented because the more powerful countries stopped it. But we cannot go on like this. Corporations and countries in the global north, the wealthier countries, cannot keep on putting profit over people, because the dynamics that drives this is also what is driving us towards the climate catastrophe. So it is not just about wanting to be good. We are talking of an existential problem here. We're talking of an existential situation. And they often say that, okay, things take time and all that. But COVID-19 also showed that it is possible to take radical steps. What happened is that the only difference between the climate crisis and COVID-19 is that the climate crisis is a slow motion version of what was compressed into those first few months of 2020. You know, and yet it's I'm sorry, but it's actually nauseating. You know, however, let's also face the fact here. Steve Biko said something to the effect that the extent to which the oppressor can oppress the oppressed is at least partly, I'm paraphrasing him here, is at least partly determined by the oppressor's readiness to, it's like is the oppressor swallowing the narrative of the oppressed. It's like what Bob Marley was talking of, emancipating ourselves from mental slavery. There's the need for unions, both within our ranks, but in broader society, to deepen education, to deepen mobilization, and to deepen organizing for systemic change. We cannot avoid the need for, as I said earlier, those granular things. I mean, we have every right to fight for better wages, improved working conditions, the entire gamut of the decent work agenda. But we need to, this needs to be tied to the broad struggle for a change. Even if we survive it now, generations after us won't, because putting profit first, putting wealth before health, will do us no good. In fact, it has done us no good. It is driving the world down the road of perdition. And quality public services are central to reversing that trend, because quality public services, universal access to quality public services, ensure more inclusive societies and ensure that people are put over profit and the commodification process of human society.
Thank you very much, Baba. Really, thanks for those words. Very inspiring words. And yes, and for sure, like we keep looking to the ones that create the problems for solutions. And I think kind of we are in the same line in terms of the urgent need to even decolonize our imagination about what is possible and then really push for that. So really, really interesting. If there are no other questions, I would like to really thank Baba again for very, very interesting talk as always, and very inspiring and powerful. So thank you for that. And thanks everyone for the questions and for participating. And see you tomorrow in the next workshop.